Hello and welcome to another Piper Pod. This particular subject has been coming up a lot. I've been talking to junior medics, senior medics alike, and there just seems to be a lot of confusion, maybe surprising to some, but a lot of confusion around GCS, its relationship to AVPU, and what it really means for the patient when we give someone a GCS score, and what we're actually looking for, and what we should do as far as our treatment goes in translation from those scores itself. Okay, so today I'm hoping just to shed some light on the relationship. My opinion, obviously backed up by a bunch of research and experience that I've had myself in teaching and dealing with patients too, but just a general idea of how to work a little bit better in the space of levels of consciousness. So as a means for some background on GCS, it's actually, it's pretty old. It was invented in 1974 by a bunch of neuroscientists, and its main focus was to deal with brain injuries and a way to quantify the level of someone's brain injury against others, and also their decline or their improvement of that particular brain injury. Now obviously from that point in time, it's also been quantified as really useful in state of emergent situations, or people that are in a medical emergency or a traumatic emergency, as a good way of demonstrating their patient status by means of level of consciousness. It's almost universally picked up as well, so it's a language that many different countries speaks, and also a lot of different services speak as well. So if you say GCS to any hospital in Australia or ambulance service, they'll know exactly what you're talking about, or at least they'll know what a GCS is. Okay, so it's translated really well. A lot of confusion comes around, a lot of time when you're dealing with alert patients, they tend to be, the first question comes up and people generally try to ask a high cognitive based question, like, do you know who the Prime Minister of Australia is? Now obviously there's been time periods recently that no one knew who the Prime Minister of Australia was. It kept changing every week, so obviously that was more of an aptitude or cognitive based question as opposed to actually dealing with their level of consciousness. It also doesn't assess someone's memory ability or generally intelligence, so when you're asking questions around orientation, just keep that in mind. We'll talk a little bit more about that later on, but just be aware that it is not a cognitive based assessment. It is purely in place to check someone's level of consciousness. Now, depending on the patient you're dealing with, there's a lot of difficulty in translating mostly the verbal response associated with people that have cerebral impairments. So say if you have a global disorder, you're generally going to be more confused or maybe ramble words or inappropriate grunts, which obviously on the GCS will put you at a lower score, but that is your general state. So translation in that particular case does get lost and really needs to be handed over when you're dealing with those patients. If you have a patient that refuses to speak or cannot speak for whatever reason, that they're mute, okay, that needs to be translated as well. So don't just put them down as a 1, as in they didn't talk, because that's obviously going to significantly lower their GCS when they're actually quite alert, just unable to speak. So make sure you mention those ones. Same to the fact that if you have a language barrier, so they're not understanding the questions, they're not willing to talk to you, language, cultural barriers, that sort of thing, make sure that's recorded as a not taken as opposed to a 1 in the verbal setting. That's generally where a lot of the difficulty comes with the verbal side of the house. From that, it's just generally can be confusing for people to remember the numbers associated with different categories and what it actually means when you see that on a patient. When GCS was first invented, the way to write out a GCS was not as a single number like we tend to use these days, which is like GCS 15, GCS 3. You actually were encouraged to differentiate your values. So you'll give somebody a E4, V5, M6 as opposed to a GCS 15. Okay, and now there will be places that you may work that will still expect that. Generally when you're dealing with neuro, be expected to do that sort of thing. For our practice, we're dealing with emergency departments, pre-hospital care, the universal GCS number is widely accepted and utilised pretty much in all situations. So let's go through it. So we've all seen it. We've all seen these words. Okay, breaking up into three categories. It's got to do with eyes, verbal, and motor response. Now, eyes are, you'd think, pretty easy to understand. Okay, but generally around the voice spontaneous region, people tend to get a little bit confused. So when it says someone's eyes open spontaneously, it means, one, they're either opened, or with minimal stimulus, they stay open. Okay, so if you need to talk to someone initially to get their eyes open, and they stay open, they actually get a 4, not a 3. It's only when you have to continuously give someone verbal stimulus do they get a 3, which is eyes opening to voice only. Okay, we'll talk more about that when we connect it to AVPU, but that tends to be the confusion. The same true is pain. If someone is eyes are closed and you have to give them a pain stimulus because they're not listening to you, and they open their eyes, but then they stay open, they actually get a 4. You don't go off the initial pain response. Okay, now I apologise if that's a little bit suck eggs, but I've seen people record it down as 2 or as 3 because they needed to have an initial stimulus in order to get them going. Okay, when we're dealing with the verbal side of the house, orientated generally means to time and space, and that's where it gets a little bit confusing, especially for our demographic, because if you're in a field environment and you ask a simple question like, what day is it? I don't know about anyone else, but when I'm out field, it's Monday plus however many days you've been out there. So it's really hard to keep track of what actual day it is when you're disassociated from the rest of the world. Okay, so sometimes asking what day it is not always the best question. Confusion is just that. Okay, they have sustained confusion, but they're adamant about their confusion. They're still in a conversation, but it's difficult to keep track. When we move down to inappropriate speech, it does not mean that the person is swearing necessarily. Okay, I had a lovely aged care worker working with the ambulance. We went to the nursing home to pick someone up, and they gave the person a 3 for verbal because the patient swore at her. And no judgment, it was just a quite a cute story, but just know that when you're talking about inappropriate speech, it's more your random or your non-uniform speech that just sort of goes off, like the ramblings of an old man, much like this podcast is at the moment, I'm sure, for a lot of you, just the ramblings of someone not making sense. That's when we're dealing with inappropriate speech. Okay, it does not represent or relate to the conversation. Incomprehensible is nice and simple. It doesn't mean they're saying words you don't understand. It means that they're grunting, groaning, making sounds, mumbling under their breath, that sort of thing. Okay, so that's what we're looking for when we're dealing with the verbal response in that sort of dissension. Motor responses are notoriously difficult once we get down past 4. Okay, so the 6 obeys command, that's nice and easy. If they open your eyes, okay, even if they're only responding to voice and they're mumbling, but they're still opening the eyes to voice, then they're still obeying commands. So they still get a 6. It's nice and simple. Okay, if they're able to squeeze your hand, if they're able to follow any direction, if they're able to get the information in, process it, and then give a motor response based on on what you're saying, then that is obeying commands. Okay, it does not have to be complex. Okay, as a matter of fact, should not be complex. From 5 down, you're essentially looking at pain responses. Okay, so localizing to pain, which means when you're doing a painful stimulus, the person is able to feel that stimulus and then localize to that exact area. So if you're pinching someone's nail bed, they are able to grab that nail bed that's in pain, or they're able to identify where exactly that pain stimulus is coming from. Okay, that's obviously pretty good. When you get to withdrawing from pain, now the textbooks will let you know that someone withdrawing from pain is essentially someone moving away from that painful stimulus. So again, you get the nail bed and they will pull it away. Okay, squeeze the nail bed, they pull their finger away. Now, to let you know, that's often confused with localizing to pain. Okay, it's very, very common to confuse that with localizing to pain. It's also very common to confuse abnormal flexion to withdrawing from pain or localizing to pain, believe it or not. And in fact, a study was released that essentially assessed a whole bunch of neuroscientists, so people that would actually work in this field regularly, and there was 50% of the time that they were quantifying motor responses, like 50% of the people who were assessed would have some disagreements around 3, 4, and 5 for your motor response. Okay, so don't feel too bad if you're not quite on speed, because these are people that will do it every day, and their cohort are the ones that invented this particular table as well. Okay, so it can be difficult. So when you're dealing with abnormal flexion, you're looking at flexions of the particular muscles. Now, a certain muscle group you should not look at for your abnormal flexion or extension is the actual feet. Okay, because in both of them, abnormal flexion and extension, they'll actually point their toes down. Okay, so for painful stimulus, they'll actually point their toes down, but the difference is an abnormal flexion, they'll have a flexion of the arms, the wrists, and the fingers, as opposed to an extension of the arms, the wrists, and the fingers. Okay, and also can have the legs. It's less common, but the legs can be involved. Okay, so when we're looking at 3 and 2, so abnormal flexion, abnormal extension, it's pretty always associated with head injuries. Okay, so you're not going to get those responses from somebody who has had traumatic, so has lost blood, has lost their GCS as a result of lack of perfusion or something like that. This is literally pressure on the brain sort of thing, especially when we're dealing with abnormal extension. It's actually quite common to have somebody with real significant head injury to naturally be in this decelerate state even without painful stimulus. Okay, so they're universally, as far as what I've read, associated with head injuries as per their initial design. Okay, so when you see any form of abnormal flexion or extension, you can pretty much bet your bottom dollar that it's associated with raised intracranial pressure or some form of cerebral injury. Okay, so that's an overview of them, of the GCS. Now, it does take practice to get these down pat. And to be really good at GCS, I'm not saying I am, or any sense of imagination, because I haven't seen many people below 13, really. Because it's unusual to see someone with a GCS below 13 as far as all patient status goes, okay, especially below 10, which is considered a severe injury. So trying to get absolute tone skills for anywhere between 3 and 10, it does take a lot of practice and a lot of experience to do so. Don't beat yourself up if you cannot rattle off the GCS categories or calculate it in your head straight away, because it's not a normal thing to be able to do, especially early in your career. Okay, and a lot of times it's probably not going to be that helpful for you either, giving statistically the amount of patients you're going to see under 10. Okay, which is why we teach AVPU. Okay, we don't bother trying to teach CFAs, GCS, okay, because it's not really that well understood in a lot of our own heads. So we adopt AVPU. Now, just because we teach AVPU to CFAs does not mean that we ourselves cannot use AVPU or a lot of the other acronyms out there. There's a few more out there, but the most universally accepted is AVPU and obviously GCS. So next we're going to go through the relationship and how GCS correlates with those AVPU score, because a lot of people that I talk to have a pretty good grasp on AVPU, and it's just the GCS that gets that little bit confusing. Okay, so as promised, if we look at our alert status, so patients that are alert. Now, when you're alert, you're essentially said to have a GCS of 15 to 13. So the lowest you're going to have is 13, and that correlates nicely, if you will, and there's a little bit of overlap, but it correlates nicely to mild dysfunction if you're below 15. Okay, so you can still be alert in the AVPU state and have what's known as mild dysfunction. Okay, so these are the people that eyes are open or stay open after an initial stimulus. They're either orientated, a little bit confused. Now, at absolute worst, okay, and you'd be quite concerned, is if they have the inappropriate speech, so the ramblings going on. But because their eyes are open spontaneously, and they're able to come back with some form of a conversation with you, then they're associated with obeying commands. So they get full points for eyes and motor, and the variables are obviously in the verbal category for anyone that's alert. Okay, if you have an alert patient, then take a breath. You got time. Okay, perfusion's good. Injuries aren't that bad. Prognosis is pretty good at this stage as well. So alert, happy days. We're all pretty happy with alert. So 15 to 13, not too bad. Obviously watch closely for those 13 marks because they're getting close to verbal response or a lower GCS, or as I like to call them, the pain in the ass GCS. Okay, so to put this sort of GCS into context, a lot of you have probably seen this type of GCS when you go out to the pub and you have a mate that just drinks way too much. Okay, so they're at the bar and they're essentially asleep or passed out. They're not really sleeping, but they're passed out in the bar, and the only way to get them to do anything is to essentially talk to them. Go, "Oh mate, it's time to go," and they sort of flick their eyes open, give you a little bit of a grunt or a little bit of a ramble, and then their eyes close back until you talk to them again. So because their eyes are opening when you talk to them, they get that obeys commands because the next lowest is localizing to pain. You're not doing pain yet. So they stick up in the full motor. They get 3 for opening their eyes to voice, and it's inappropriate speech and incomprehensible. You may be thinking, why can't they be confused? Okay, because confusion is based on a conversation that it's having. If somebody can have their eyes open and be coherent enough to even have a confused conversation with you, then they'd be a spontaneous, they'd be in an alert state. Because they literally only have their eyes open to a verbal response, so they're only giving you anything from a verbal stimulus, they need your verbal stimulus to keep coherent or to keep semi-conscious. Okay. Now the reason they're called the pain in the ass GCS is because they're not low enough to treat as an unconscious casualty. Okay, so they're not drastically bad. This is what's considered in the charts as your moderate to severe dysfunction. Okay, usually the 11's obviously more severe, but they're not low enough to be treated as unconscious. They can't get all the good airways, and a lot of the time they're not coherent enough to give you any help, to tell you what happened, to listen to what you're saying, and no one likes carrying these people home. Okay, they're a pain in the ass. So I call them the pain in the ass GCS. Think of that pain in the ass mate that drunk too much and is now passed out at the pub. Okay, that's 11 to 12. 11 to 12, a really small window. Okay. Now, when we get down to pain for stimulus, things get confusing. Okay, because as you can see, there is a really large realm of what you can get from painful stimulus. Okay. Now, as we can see, responding to pain will get you 2 points. Now, you've got to be really careful what sort of painful stimulus you utilise for these patients. Now, the sternal rub wasp, we all have taught it, and it's all cool, and you're like a bit of a war dog grinding up on someone's chest. It's not always the best stimulus, okay? Because if you're trying to ascertain whether they're localising, withdrawing, or abnormal flexion, then they're all going to look exactly the same. if you're doing a sternal rub. Okay, because they're all going to be moving their hands towards the chest. Okay, so it's not the best one to use. Okay, sometimes it needs to be done. Someone's taken a particular cocktail of drugs and they respond to pretty severe painful stimulus. Okay, so the pinch on the earlobe, the fingernails doesn't work, the trapezius doesn't work, pinching the angle of the jaw doesn't work. But sometimes you get a sternal rub on these patients and it's the most painful. And you do get a response. Okay, so sometimes with the painful stimulus you can quantify their response of GCS by how much pain you have to give someone as well. Okay, and it's usually a pretty good indicator of their level of consciousness. Now, the absolute unicorn in this particular case would be someone who's responding to pain but has your inappropriate speech. Okay, because most of the time the best you get out of them is an incomprehensible mumble when they localize to pain and their eyes open to pain. Okay, but it is possible, and it does happen, where they can get a few words out that you can understand before they pass back out again after the pain stimulus drops. Okay, so that can happen, but you'll mostly find that this particular painful response is 9 and below, as opposed to 10 to 4. Okay, so just keep that in mind. Now, with your other responses, you can get 1 point in painful stimulus, obviously, from the eyes and the verbal. So they can keep their eyes closed, they can give you no verbal response, but then they can have withdrawal to pain, abnormal flexion, abnormal extension themselves. It's only when they have no response in the motor section as well are they actually considered unresponsive, which is why you can get all the way down to a GCS of 4 when you're using pain within the AVPU. Okay, so unresponsive obviously is nothing. No eyes, no talk, no motor. That is your unresponsive. Okay, so that's a lot of words, a lot of connections, but how are we going to utilize this information? What does this information actually mean? So obviously doing AVPU is quite quick. Okay, yes, it's the exact same test as GCS, but you don't have to do that internal calculation. You can just give someone an A, a V, a P, or a U. That's it. Nice and simple. And the correlation with it, whilst it is not 100%, okay, when you're dealing with people in an emergent situation, you can pretty much categorize people with AVPU of how worried you are about that particular person. So during a mass cas situation, you obviously have multiple casualties, and a lot of the principles of prior 1s, 2s and 3s will go out the window, because we can't just think about an individual. We have to think about multiple casualties and the greatest good for the greatest number. So we adopt the tier system of treatment, okay, and we use our sieve and we use our sort. Now, part of our sort method obviously correlates perfectly to GCS, but it's difficult because it's an extra number system on top of the GCS system, which makes it difficult to actually give people the numbers. So when you're initially on the scene, you can use AVPU to pretty much categorize your patients. Now, there will be the 1%ers that fit outside, especially when you're dealing with the verbal personnel. Okay, but as a big rule of thumb, if someone is alert at that point in time, they are a tier 3. You have time for that person. If someone is responding to voice, then they're tier 2. If they're lower end of the verbal, then they become a tier 1, and especially if you start taking into account rest rates or tachycardic, then obviously that they become a tier 1. Okay, but most of the time they're obviously not as bad as your painful or your unresponsive patients. So if you have anyone responding to pain or is unresponsive, they automatically, you really don't need to test anything else at that stage. You know full well that that patient is an emergent situation and they need immediate care. Okay, when you're dealing with airway adjuncts, obviously the lower the consciousness, or the more advanced airway adjuncts you can put in someone. So alert people, they don't need airway adjuncts. Your verbal people, pain in the arse, GCS, high end of pain, maybe you can work for an MPA. Okay, try an OPA by all means, but chances are they're going to be able to get that MPA. When you start moving into the pain, remember we're really dealing with that 9 and below. Okay, then we can have to really start considering advanced airways. I mean, you've heard the old saying, less than 8 intubate. Okay, so realistically, painful response, you need to be starting to think that this person needs airway protection. So it ups the ante of their evacuation. Okay, so that's the relationship with our GCS associated with AVPU and how we can utilise it in pretty extreme busy situations to really help tailor which patients are needed. Because the Mascaz theory of sieve and sort is fantastic. Okay, I'm a big fan of it, but it does take a lot of knowledge, a lot of memory, and a lot of ability to be able to calculate on the run. Okay, so it's not something you can do straight away. It takes practice. But AVPU is something you can do straight away. And if you have that in the back of your mind, that painful is in a real emergent situation. So if someone says that they are responsive to pain, start getting worried. That's basically what the bottom line is. Responsive to pain means they're most likely going to require advanced airway management, and they've got a lot of other associated problems. They're talking perfusion status is generally down, they're usually high compensation, starting to move on the other end of that decompensation shock. Okay, that's what a painful stimulus can mean. Obviously you get drugs and everything involved, and it literally means they've taken too many drugs, but we don't deal with those casualties a lot. I'm talking about the trauma-based Mascaz multi-casualty situation is where this sort of information can be handy. And your CCP, your clearance priorities for evacuation can be excessively handy to have this sort of information in the back of your mind. It also helps when you're training the juniors, the CFAs, the AFAs, of what sort of information they hand over on the 9-liner, because we all know they love to over-prioritise, and that's just what they do. Okay, let's accept that. But if you train them in the use of the AVPU, which is in first aid, it is in CFA, then you can actually start getting some tangible information over the radio for you to realise what sort of state this patient actually is at. Last thing we're going to finish off on is looking at the kiddies, knowing what to do with kids. Now, obviously, my training officially has never included kids. Okay, this is literally from what I've read, what I picked up, what I've got from people that work in the field, that sort of thing. Okay, so looking at the pediatric Glasgow Coma Scale, it's, as you can see, it's very similar to ours. So eyes opening, motor response, it's the same. Okay, it's the same as us. Okay, the only difference is obviously when you're dealing with motor response, when you've got the little ones under 1, they don't have the knowledge or the cognitive state to be able to obey commands. But essentially means that when you're interacting with them, they have deliberate responses. Okay, so they're actually able to have deliberate responses to you. It's pretty easy. If you're not causing pain to make a child respond, then they get a 6, regardless of what it is. Okay, so if you're using voice or anything else to make a child respond, then they get a 6 in motor, just the same as the adults. When it gets to verbal, that's when it gets insanely complex. Now, I'll let you obviously read through it. I'm not going to spill through it all because you all can read. Okay, it's part of the requirements of the job. But as you can see, there's some problems. The people over 5, they're treated exactly the same as us. Okay, adults, very young adults. Okay, but they're treated the same as adults. When you get to 2 to 5, things gets a little bit different. And the things that can be very difficult to tell the difference between is essentially when you start bringing in crying. Okay, so you see there it's crying, but able to be consoled, crying, not able to be consoled or inappropriate. Now, the parents that are listening to this are thinking, I have my own children, and sometimes I have no idea what they're crying about. They're just crying, especially when they're under the age of 2. They're just crying. So don't beat yourself up if you can't tell the difference between a 4 and a 3 when you're dealing with children's verbal response of GCS. Okay, because to tell you the truth, no one really can. So I've just found a way to generally fit it in a category, and it's mostly your motor responses and your eyes opening that play the biggest part when you're dealing with the real little ones. Okay, so from here, practice it. When you're doing scenarios, you're doing training scenarios, you're making up scenarios for your friends or CFAs, use appropriate GCSs. So don't say someone is painfully responsive